Welcome to Chapter 27, Family Development and Family Nursing Assessment. On this slide and the next are your objectives for this chapter. Family nursing is a philosophy and a science that is based on the following assumptions. Health and illness are family events. What affects one family member affects the whole family, and healthcare practices, decisions, and behaviors are made within the context of family. Lack of communication among agencies in the transfer of clients or internally within a healthcare system among providers related to incomplete or missing information, rushed procedures, or failure to follow a plan of action and standard of care result in increased incidence of hospital admissions and readmissions. Nurses need strong skills in negotiation. Service appointments would be more effective if scheduled when a family care provider or a caregiver or companion could attend the appointment. Involving family in the care of the client improves self-management of health care. It reduces medication errors and improves health outcomes. Nurses must be adept at working among healthcare systems to find resources and services for the large population of uninsured clients and families. Additionally, insurers traditionally base coverage and reimbursement on an individual's disease or health problem and not on the family unit or informal family caregiving. Lack of insurance makes finding adequate services for clients and families difficult. Many clinics are program-based, like family planning, STD, or immunization clinics, and are not focused on primary health care. Nurses help clients and families negotiate and maneuver through the healthcare system, removing barriers and providing services and resources that enhance the family's ability to provide quality care to the family members. Knowledge of family function and structures is essential for understanding how families influence health, illness, and well-being. Family functions are the ways in which a family meets the needs of each family member, the family as a whole, and their relationship to society, such as economic, reproduction, socialization, affective, and healthcare functions. Family structure refers to the characteristics and demographics, like gender, age, or number, of individuals who make up family units and define the roles and positions of family members. Family structures have changed over time. The great speed at which changes in a family structure, values, and relationships are occurring makes working with families at the beginning of the 21st century exciting but challenging. There is no typical family model. An individual may participate in a number of different types of family structures over the course of his or her lifetime, such as the family of origin, a single-parent family, a step-family relationship, cohabitation, or older single widow. New family structures that are currently experimental will emerge as everyday natural families with time, because family is a system within itself and also the basic unit of a society, evolving and thriving as they seek different ways of interconnectedness. Family demographics is the study of family and household structures and the events that alter those structures. Nurses use family demographics to forecast and predict transitional stresses, developmental changes, stresses, and ethnic issues affecting family health, and identify possible solutions to identified family problems. Family households include a householder and at least one other member related by birth, marriage, or adoption, whereas the non-family household is either a person living alone or a householder who shares the house with only non-relatives, such as boarders or roommates. Family demographic trends have continued in the direction of fewer married couples with children households. Large households have decreased and small households have increased. The average household size remains at 2.6, but the source of that size has changed with increased racial and ethnic diversity, increased individuals living alone, and increased households of those 65 years of age and older. Marriage, although still a popular American ideal, has assumed a forerunner, cohabitation. Cohabitation is a couple living together who are having a sexual relationship without being married. People cohabit for 3 reasons: economic reasons, egalitarian relationships, and a trial period. There are also ethnic factors to cohabitation. Whites viewing cohabitation for trial period, the African Americans and Hispanic Americans viewing cohabitation as a substitute for marriage. Cohabitation is also of increasing importance among older persons. Duration of marriage is associated with age at first marriage and timing of the first child. Education was a factor in both men and women's duration of cohabitation, with lower education associated with longer cohabitation. As cohabitation increases, ensuring STD reduction and family planning services becomes essential. Most children born into families with Two additional trends in marriage are increased age of the first marriage, possibly related to educational attainment of women, and increased number of interracial marriages. Later marriages can lead to older women becoming pregnant and complications attributed to later life pregnancies like infertility, STDs, and increased OB complications. The shift in race and ethnic diversification has implications for American women's fertility and participation in public health government assistance programs and needs for interpretive services. Fertility rates differ by race and ethnicity. Hispanic women have the highest fertility rates and white non-Hispanic women have the lowest. Not all cultures value limiting the number of children in a family. Divorce can be said to be increasing, declining, or remaining stable depending on the time reference. The following factors lead to divorce: women's independence in the marriage, money issues, lack of education, poor social skills, inability to manage conflict, sexual incompatibility, alcohol and substance abuse, risk-taking behaviors, and religious issues. The divorced family is affected in the following ways: the diminishment of the father's role in the family, a negative impact on the children, emotional problems for a number of persons involved, and reduced living standards. The economic hardships of divorce and cohabitating dissolution are similar. The characteristics of people who divorce vary by race, religion, and educational level. Because women are still the dominant custodial parent, the economic adverse effects they suffer are also experienced by the children. Bereavement as the leading cause of remarriage has been replaced by divorce. More than 50% of divorced people remarry. The person who initiated the divorce has replaced gender as the leading factor in remarriage rates. For middle-aged families, this results in more blended families and issues of childcare. Nurses must keep informed and up-to-date about demographic trends pertaining to families to identify high-risk populations. Changing demographics have implications for health planning, resource development, and allocation of limited community resources. Demographics are typically updated every 5 years. The term family health is often used interchangeably with the concepts of family functioning, healthy families, and familial health. Family health can be viewed as a dynamic, changing, relative state of well-being, which includes the biological, psychological, spiritual, sociological, and cultural factors of a family system. This holistic approach refers to individual members as well as the family unit as a whole and the family within the community context. Health professionals have tended to classify families as healthy families and non-healthy families, being those in need of psychosocial evaluation and intervention. Family health has implied the mental health of the family rather than the physical health of the family. Non-healthy families were often referred to as dysfunctional families, being either non-compliant, resistant, or unmotivated. These terms limited the opportunity for families to change and posed barriers to interventions. Families are neither good or bad, and all families have seeds of resilience where interventions can be successful. Families with strengths, functional families, and balanced families are terms that are often used to refer to healthy families that are doing well. Family resilience is defined as the ability to withstand and rebound from adversity. Balanced families are those that have the ability to adapt to situations. Therefore, they demonstrate family flexibility in leadership, relationship, rules, control, discipline, negotiation, and role sharing. Balanced families have the ability to allow family members to be independent from the family, yet remain connected to the family as a whole, which is termed family cohesion. The family is viewed from the following 4 perspectives. The traditional perspective of family as the context places the individual family member in the foreground and the family in the background. This family serves as either a strength or a stressor to the individual. In the family as client approach, the family is in the foreground and the individuals are in the background. The family is seen as the sum of the individual family members. The focus is on ways the individual members affect the whole family. In the family as a system approach, the family is seen as the interactions and relationships between the family members that become the target of the intervention. In the family as component of society approach, the family is viewed as the primary unit of society and as part of a larger system. This approach is used by public health nurses as they implement population-centered strategies to improve the health of the overall community. There is no single theory or conceptual framework that fully describes the family relationship and dynamics or be used to understand and intervene with families. Community and public health nurses must also blend family nursing theories with public health theories and frameworks. Family nursing is an evolving synthesis of the scholarship from 3 different traditions: family social science, family therapy, and nursing. The family social science theories are the most developed and informative with respect to the family function, the environment-family interchange, interactions within the family, and how family changes over time, and the family's reaction to health and illness. 3 family social science theories that blend well with community and public health nursing are family systems theory, family development and life cycle theory, and bioecological systems theory. Family systems theory. Families are social systems. A social system is composed of a set of organized, complex, interacting elements. The purpose of the family system is to maintain stability through adaptation to internal and external stressors that are created by change. Assumptions of the family systems theory include that family systems are greater than and different from the sum of their parts. There are many hierarchies and logical relationships within family systems and subsystems. Boundaries can be open, closed, or random. They increase in complexity over time. Family systems change constantly. Change in one part of the family system affects the total system. Family systems are organized as a whole, interdependent, and family systems have a homeostatic feature, adaptive or maladaptive. Family systems theory encourages nurses to view both individual clients as participating members of a whole family. emphasizing the whole, helping families to maintain balance and stability. Nursing assessment addresses the individual members, subsystems, boundaries, openness, inputs and outputs, family interactions, family processing, and adapting and changeabilities. Interventions must build on the strengths of the family to improve and support functioning at the individual and family level. The major strength of the systems framework is that it views families from both subsystem and suprasystem approach. The major weaknesses of the systems framework is that the focus is on the interaction of the family system with other systems rather than on the individual, which is sometimes more important. Family developmental and life cycle theory. This theory provides a framework for understanding normal predicted stresses that families experience as they change and transition over time. The stages of family life cycle are based on the age of the oldest child with associated family developmental tasks at each age. Family disequilibrium and conflict occurs during these expected transition periods from one stage of family development to another. Families change and develop over time based on the age of the family members and the societal norms of society. They have predictable stressors and changes based on changes in the family development and family structure. Families experience disequilibrium when they transition from one stage to another. Nurses can use these predictable stressors in their assessment to identify family strengths and adaptation to change. Nursing intervention strategies help individuals and families understand the growth and development stages and manage normal transitions between developmental periods with the least amount of stress. The strength of this approach is that it provides a basis for forecasting what a family will be experiencing at any period in the family life cycle. A major weakness of the model is that it was developed at a time when the traditional nuclear family was emphasized, although some progress has been made in looking bioecological systems theory. This theory describes how environments and systems outside of the family influence the development of family over time, nature, and nurture, and is very useful in community and public health nursing to identify the stresses and potential resources that can affect family adaptation. The family as the client is at the center, and the roles, rules, and norms that influence the current situation of the family are addressed. The strength of this model is that it provides a holistic view of interactions between the family and society. A family eco-map is typically used to graphically represent these interactions and the flow of energy. The weakness of this model is that it does not address how families cope or adapt to interaction within these systems. Working with families for healthy outcomes. Family nurses should transcend the traditional nursing approach as a service model and change their practice to a capacity building model. The nurse assumes the family has the most knowledge about how their health issues affect the family, supports the family decision making, empowers the family to act, and facilitates actions for and with the family. The goal of family nursing is to focus care, interventions, and services to optimize the self-care abilities of the families and achieve the best possible outcome, understanding that each family is unique. Plan for family assessment. Ask these questions. Why are you seeing the family? Are there specific family concerns that have been identified? Is there a need for an interpreter? Who will be present? What are the insurance sources for the family? Using excellent communication skills, nurses help families determine the priority of issues they are confronting, identify their needs, and help develop an action plan. Nurses use a myriad of sources, such as a referral source, family, and previous records. Often the decision on where to meet the family will be determined by the type of agency with which the nurse works, home or office. There are advantages and disadvantages to each setting. The nurse then contacts the family. At this point, the family is also making first impressions about the nurse. Therefore, the nurse should concisely state the reason for requesting a family visit, encourage all family members to attend, determine whether an interpreter will be required, and arrange several possibilities for appointments to allow the family to select the most convenient time for all family members to be present. Remember, families ultimately retain control of the situation. The nurse should learn about the neighborhood she'll be visiting, anticipate needs, determine whether it's safe to go alone, leave a schedule at the office, and carry a fully charged cell phone. One of the underlying central tenets of family nursing is to build a trusting family-nurse relationship, using therapeutic communication efficiently and skillfully by moving between informal conversation and skilled interviewing strategies involving each family member, and sending the message that the purpose of the visit is to help the whole family and not just the individual family member gather information and help the family focus on their own problem and determine solutions. Therapeutic questions you might ask include, what is the greatest challenge facing your family now? On which family member do you think the illness has the most impact? Who's suffering the most? What has been most and least helpful to you in similar situations? If there is one question you could have answered now, what would that be? How can I best help you and your family? And what are your needs or wishes for assistance now? Nurses gather information using reliable and valid short assessment instruments that are specifically focused on the relevant family situation. Families should always be asked for permission to use an assessment instrument, informed of how the information will be used, and have the results or interpretation of the information reviewed with the family. Genograms and ecomaps are both assessment instruments that actively engage the family. The genogram displays pertinent information in a family tree that shows members and their relationships over at least 3 generations, the family history, the patterns of health-related information, and identified client, using standard categories and formats to capture the information. The ecomap is a visual diagram of the family unit in relation to other units or subsystems in the community, showing the nature of a relationship and the direction of energy flow. This is a tool to organize and present information in a holistic, integrated way. Functional health literacy includes the ability to read and understand numbers and to use health information to make informed decisions. Nurses can assess for health literacy and employ certain visual techniques that help families retain information more, to follow directions and make informed decisions. Nurses will be challenged to help families identify the primary problem confronting them and step aside and accept the family priority as they work in partnership with the family to keep their intervention simple, specific, timely, and realistic. It's important to use this open approach because the central issue identified by the referral source may not be the actual problem the family is experiencing or the actual family concern. The nurse works with the family to design realistic steps or a plan of action based on their ability to successfully adapt to the health issue given the strengths of the family, to prevent a potential problem, minimize a problem, stabilize a problem, or recognize that it is a deteriorating problem. The nurse knows that what affects one member of the family affects all members of the family. Nurses engage in critical thinking to determine if the plan is working, determine what barriers are interfering with the plan, such as apathy or indecision, or what has changed about the family story. There are also nurse-related barriers to consider: nurse-imposed ideas, negative labeling, overlooking family strengths, or neglecting culture or gender implications. Termination, phasing out the nurse from family involvement using specific strategies, is also an important part of the evaluation step. The family is given credit for the outcomes, and a summative evaluation meeting is conducted. Social and family policy challenges are part of the nurse's practice. Government actions that have a direct or indirect effect on families are called family policy. The range of social policy decisions that affects the families is vast. However, there's no explicit national family policy in the United States. Most government policy indirectly affects families. The Family Medical Leave Act of 1993 is one type of positive family policy, allowing family members to take a defined employment leave without fear of losing their job. The Affordable Care Act of 2010 is intended to address other issues of interest to families that will hopefully address gaps in existing programs such as Social Security and temporary assistance for needy families. It's crucial for nurses to be actively involved in the development of family health policy, and nurses must lobby for overt family policy. Families face many challenges such as immunizations and shortages of vaccines, legal definition of a family, reproductive and fertility issues, family leave, elder care, caregiver support, immigrants and refugees, healthcare insurance, uninsured, underinsured status, and rising costs of healthcare services, deductibles, and co-payments. Families depend on community health nurses to serve as a buffer between social policy and how these policies affect the everyday lives of their clients.